It's the recordings. Yeah.
Okay.
So thank you very much for the very nice introduction, Alejandro, and good morning, everyone. So today I would like to talk about balancing immediate surgical risk with deferred benefits in preventive surgery. And while the title says preventive surgery, this is really applicable to any preventive procedure, which includes early risk or early harms. And this talk might be a bit more clinical than the other talks, but I saw that lots of clinicians joined today, and I'll make sure that everyone can follow it. So we would like to challenge how we analyze the current preventive interventions, and I would like to propose a new approach that might change our current conclusions. So when we look at trials for preventive interventions, we see that they are structurally different from the most trials for therapeutic treatments. In therapeutic treatments, both the intervention as the control arm consists of patients who already have some type of disease or condition. And that condition often justifies some of the treatment harm. However, in preventive interventions, by contrast, we intervene in individuals who are currently asymptomatic but who are at risk of developing an adverse condition or event in the future. So the treatment harm is only justified for those who would have developed the adverse condition, and we don't know that upfront. A second aspect in these preventive trials with upfront risk is that there's an important timing aspect, because the intervention harms patients at the onset of the study or the trial, while the prevented event might have occurred later in time and thus affect less lifetime than the intervention harm. In other words, with our treatment, we are introducing events at an earlier point in time. And this creates a fundamental asymmetry or dilemma, because the intervention itself introduces a real and immediate risk, but the benefit, in contrast, is deferred, and only for a subset of the patients, those who would have experienced the event. And when we translate this preventive dilemma into time to event analysis, it produces a very characteristic Kaplan-Meier pattern. First, we often see early access risk in the intervention arm, which reflects the treatment-induced events like procedural mortality or perioperative complications. And then over time, we see a lower event rate in the treatment arm, and the curves converge and may cross over time. Statistically, this is a clear non-proportional hazard situation because the treatment effect is strongly time-dependent. And only later in time or in follow-up, we see the apparent benefit appear when events start to accumulate in the control arm that might have been prevented by the treatment. So this single figure captures the core structural feature of preventive trials: early harm and delayed and conditional benefit. And more importantly, this is not only a theoretical construct, but we see the same pattern emerge across various medical specialties. For instance, in cardiology, the PROTECT-AF trial, they randomized patients with atrial fibrillation to a minimal invasive device or minimal invasive procedure versus long-term anticoagulation by warfarin. And they aimed by that to prevent future cardiac strokes. And when we look at this Kaplan-Meier curve, we see early access of events in the device arm, the blue-grayish arm, and which reflect the perioperative procedural complications, and the benefit of the procedure emerges later during the follow-up. We see a very similar structure in the recently published CREST-2 trial in the New England, where patients were randomized to intensive medical treatment, which was reflected by the gray arms, versus medical therapy, plus some surgery, some carotid revascularization, reflected by the blue arms. Again, the early part of the trial is dominated by treatment-related events, while the later differences are driven by the accumulation of spontaneous strokes. And a third example is the A61 trial, which is a landmark randomized controlled trial comparing immediate carotid endarterectomy, a type of vascular surgery, with deferred surgery. And all of these examples show the same pattern: the immediate risk in the treatment arm with any preventive benefit arising later in time. And as you all could see, all these studies use Kaplan-Meier time-to-event analysis for their results. However, analyzing the efficacy of these trials with Kaplan-Meier alone might introduce a few problems in preventive interventions. And the first problem is that Kaplan-Meier estimates risk in a hypothetical world without competing events. It uses non-informative censoring, assuming that all patients who are censored have the same future event risk as those who are still in the observation. And this is often correct, because when a patient simply decides not to participate in the study or that does not alter their risk of event. But it goes wrong when patients die from other causes, because death ultimately removes individuals from experiencing any event of interest. Yet Kaplan-Meier treats these deaths as if they were just lost to follow-up. And as a result, Kaplan-Meier overestimates the actual risk. The second problem is that Kaplan-Meier quantifies whether events occur, but not the lifetime impact of these events. And this is especially relevant in preventive procedures with early harm and delayed benefit, because the treatment arm is disproportionately affected by early events. Yet Kaplan-Meier does not distinguish between an early or a late event, and events at time point 0 are weighed kind of identically as events 5 years later. And in a setting where we explicitly trade immediate harm versus delayed benefits, this timing aspect should really be incorporated in our analysis. And the final problem is that early procedural risks almost inevitably violate the proportional hazards assumption. And this precludes the use of Cox proportional hazards model, and it affects the validity of the log-rank test. And many trials therefore fall back to end of follow-up absolute risk differences, which is a valid estimate, but it's very time sensitive and therefore less informative. And in some cases, the trials even exclude the early procedural events from the analysis in order to restore the proportional hazards. While this may indeed simplify the statistical analysis, it fundamentally alters the clinical question from, is this preventive treatment beneficial, to a question more like, how beneficial is this treatment after it has been successfully performed? And the latter question ignores all the procedural or surgical risk, which is not really realistic or fair towards our patients. So what should we be estimating? If preventive surgery exposed every treatment patient to an immediate risk, but only benefits a subset much later, then the question is not only whether an event happens, but it is also when it happens. And a perioperative event and an event 8 years later should not be analyzed as equivalent experiences. So what we actually should quantify is how much event-free lifetime is gained or lost over the follow-up. So the solution to our first problem, where Kaplan-Meier lives in a hypothetical world where nobody dies, is actually pretty straightforward. We can use a real-world estimate that calculates the cumulative incidence of events in the presence of competing risks. And that is exactly what the Aylen-Johansson estimator does. It treats death as a competing state and rather than as censored, and thereby it provides more realistic risks. But after switching to competing risk analysis, we are still only answering the question of whether events occur and not what the impact of those events is. And that is where restricted mean survival time, or restricted mean event-free time in our case, comes in. Restricted mean survival time, or RMST, integrates the survival curve over time. So it quantifies the average event-free time up to a specific horizon. And thereby it naturally weighs the early events more, or higher, it gives a higher impact than the late events, because an early event removes more event-free time and decreases the average substantially more than an event in the middle of follow-up. And when we calculate this restricted mean survival time for both arms, the treatment arm and the control arm, and we take the difference, then we have our treatment effect, which is not dependent on the proportional hazards assumption. So, to illustrate the impact of this other or more appropriate analytical framework, we applied it to the landmark trial, the ASYST-1, the asymptomatic carotid surgery trial. And this was a large multi-center randomized trial assessing 10-year stroke prevention after carotid endarterectomy in patients with asymptomatic carotid stenosis. And for those who are less familiar with this disease or this procedure, these terms, let me briefly explain the clinical background. So, as we age, our arteries are affected by a process called atherosclerosis. And this means that plaques form in the inner vesicle and can progressively narrow the lumen. And thereby it causes a so-called stenosis and may disturb the blood flow. And when this process affects the carotid arteries, the arteries located in your neck, it becomes particularly dangerous, because these plaques can become unstable and generate emboli that travel to the brain and thereby cause a stroke or sometimes death from a stroke. So when patients are found to have a severe carotid stenosis, they may be referred to a vascular surgeon, even if they are asymptomatic at that time and have not experienced a stroke yet. So the vascular surgeon can perform a procedure called carotid endarterectomy, which you can see on the right. And the surgeon simply opens the carotid artery and removes the plaque with the aim of preventing the future strokes. However, as you can imagine, this is not a risk-free intervention. Manipulating the plaque itself can induce a stroke during or shortly after the surgery. Secondly, the procedure and anesthesia also carry a risk of death. So by design, this intervention introduces immediate risks, the perioperative stroke or death, in order to reduce the probability of a future stroke that might have occurred years later. So the ACST1 trial studies this type of surgery by comparing optimal medical treatment alone versus optimal medical treatment with immediate carotid endarterectomy. This is by a typical example of a preventive surgery. So when we look at the ACST1 structurally, this trial consists of 4 outcome domains. At the left, we can see the harms by the surgery, which are perioperative stroke or perioperative death. And at the right, we see the deferred benefits, the prevention of a future stroke, and thereby also prevention of a fatal stroke, so a death due to a stroke. So since this trial is explicitly about trading immediate harm against delayed benefit, we could use it as a case example to see the impact of our alternative approach. So we first asked the trial investigators for the anonymized individual patient data, including treatment arm, time to stroke, and time to death. However, due to regulatory and privacy restrictions, this data was not available. But the publication and its supplementary material contained very detailed information about the population, so therefore we started the reconstruction of the data. We digitized the published Kaplan-Meier curves and used its X and Y coordinates combined with the reported number at risk and patient years to recreate individual patient data with high accuracy, which is a valid method which has been used many times. The remaining challenge was the computing mortality. ACST1 reports how many patients died in each arm over the 10-year follow-up, which was about 40% because these are older patients, but they did not mention when the patients exactly died. And to model this, we used external randomized trial by Vrijenhoek et al., which studied 10-year mortality after successful carotid endarterectomy in a population with a very similar age and similar sex distribution. And this trial showed an approximately linear mortality pattern over time, which you can see on the right. And we used this shape and scaled it so that the total number of deaths exactly matched those reported in ACST1. And this provided a plausible time distribution for computing mortality. And as you can see, our reconstruction was quite successful. On the left, you can see one of the original ACST1 Kaplan-Meier curves, which shows only non-perioperative strokes. So the procedural events have been excluded here and are not valued in this particular analysis. And on the right, you see the same endpoint based on our reconstructed individual patient data. As you can see, the shape of the curves, the separation between the lines, and the timing of the events are very similar. And this suggests that our reconstruction closely reflects the original trial data. And when we look at some harder validation metrics, we see the same picture. All key metrics of the reconstructed data fell within about a 1% margin of the original ACST1 trial data. And more importantly, the published primary endpoints, which is absolute stroke risk reduction at 5 years and at 10 years, are exactly similar to the reconstructed primary endpoints, thereby supporting the validity of those reconstruction and its use for further analysis. So now we can apply our new analytical framework or our alternative analytical framework to ACST1 data. And let's start with the first benefit domain, stroke prevention. You can see the 4 domains in the upper right corner, and the ones we are assessing is highlighted for each slide. So in the left graph, you can see the reconstructed Kaplan-Meier curve, including only the non-perioperative strokes. So again, the perioperative complications like death and stroke are excluded in this analysis. And the dashed line is the original ACST1 curve, and the solid line is our reconstruction accounting for computing mortality using the Aylan-Johnson estimator. And as expected, the original Kaplan-Meier overestimates the real-world stroke risk. When we account for computing mortality, the 10-year stroke risk decreases from 16.9% to 13.6% in the deferred arm, and from 10.8 to 8% in the immediate treatment arm. And as a result, Kaplan-Meier also overestimates the actual risk reduction, so the benefit of the treatment. The benefit of treatment was 6.1% stroke risk reduction at 10 years and decreased now to 5.6%. And if we now move from risks to time and translate this into restricted mean stroke-free time, so that is the time a patient has lived but not experienced a stroke, the Kaplan-Meier analysis suggests a substantial benefit. Based on the original curves, carotid endarterectomy is associated with a gain of about 170 stroke-free days over 10 years. In other words, the 6.1 absolute stroke reduction corresponds on average to living almost 6 months longer without experiencing a stroke. However, when we apply this restricted mean stroke-free time to the curves that account for competing mortality, this apparent benefit is attenuated. The gain in stroke-free time by immediate CEA decreases from 170 days to 72 days and is no longer statistically significant. But we learned that carotid endarterectomy did not only prevent strokes, it also directly causes strokes by the procedure. And in particular, it can cause both perioperative strokes and perioperative death. In the original publication, these early harms were reported together as a composite endpoint, any stroke or perioperative death. However, stroke and death clearly do not have the same impact, so therefore we separated these two events. Using this figure and the supplementary event counts, we isolated the perioperative strokes from the perioperative death, and this gives us a dataset in which perioperative strokes are modeled explicitly, independently of the mortality, allowing us to quantify their specific contribution to harm. So let's add them to our analysis. So instead of looking only at long-term stroke prevention, we now model the full stroke experience, immediate procedural strokes, plus the later spontaneous strokes, while we still account for competing mortality. And when we calculate the restricted mean stroke-free time, so the time patients live longer without a stroke, the apparent benefit drops further. The net gain is now about 40 days instead of 72 days at 9 years. More importantly, the restricted mean stroke-free time is negative during the first 3 years. And this reflects the early harm from surgery. Only after 3 years, the benefit starts to appear. In contrast to what the reader might conclude from the standard Kaplan-Meier, which shows crossing of the curves around 1 year. But we learned that carotid endarterectomy did not only cause strokes, it also causes perioperative death. And in ACST1, the perioperative mortality was about 1%, which is 17 deaths in the immediate arm and 3 deaths in the deferred arm. So using the competing mortality distribution, we can translate these deaths into life years lost. So for each patient who dies because of the surgery, we estimate how much life expectancy is removed by subtracting the observed survival time for those patients from the expected survival time of the study population. And what becomes very clear is that timing dominates the impact. An immediate perioperative death costs on average 7.8 life years because it occurs at the very start of follow-up. But a death in the deferred arm, where the surgery was performed later, the death cost about 4.7 life years. And fewer life years remain for those patients. So when we aggregate this over the population, immediate CEA results in a mean loss of 28 life days at 10 years, purely from the perioperative mortality. So here we show that a small risk for everyone at treatment onset has a disproportional effect on the population. But CEA does not only cause perioperative death, it also reduces death from fatal strokes. And we assess this in exactly the same way as the perioperative mortality by quantifying how much survival time is lost due to fatal strokes in each treatment arm. So the deferred arm experiences more fatal strokes because it experiences more strokes and therefore loses more lifetime due to stroke-related mortality. When we express this differently, we could say that immediate CEA, so the surgical treatment, results in lifetime gained by preventing these fatal strokes. Because the exact survival time after a stroke is not observed in ACST1, we modeled several plausible post-stroke scenarios. And here I show the most realistic scenario informed by Swedish registry data. And under this scenario, immediate CEA is associated with a gain of approximately 9 life days over 10 years by reducing more fatal strokes. So when we combine the time lost due to perioperative death with the time gained by preventing fatal strokes, we can estimate the net mortality effect. On average, we could say that immediate CEA is associated with a net loss of about 19 life days per patient over 10 years. So, when we take a step back, the original ACST1 analysis, based on traditional survival metrics like Kaplan Meier, reported a 10-year absolute stroke reduction of 6.1%. But when we apply this alternative analytical framework that is more appropriate for settings with immediate harm and deferred benefit, the trade-off looks quite different. It becomes something like living about 40 days longer without a stroke, offset by a loss of 19 life days, mainly due to the perioperative mortality. So to conclude, when we use this alternative analytical framework, we get a better view of the investment versus benefit balance. And this framework explicitly integrates if events happen, when they happen, and what they cost in time. It captures the impact of low-frequent perioperative risks and translates these results into more tangible metrics such as life days lost or gained and event-free time. And more importantly, this is not only limited to carotid surgery. This framework is applicable and should be used for essentially any preventive intervention where treatment harms first and benefits later. Of course, there are several limitations. First, this case study is based on reconstructed individual patient data, not original patient data. And our reconstruction appeared to be very accurate, but we do not know what the results would be if we applied these methods to the original trial data. That being said, it is also important to stress that this work is by no means intended to critique the ACST1 investigators or their findings, but we use this study purely as a clear example of preventive intervention with early harm and delayed benefit. Second, the timing of competing mortality was inferred from an external cohort, which inevitably introduces some modeling assumptions. And third, our restricted mean stroke-free time difference have relatively wide confidence interval. And this is partly due to the low number of strokes, the heavy censoring, but also due to the additional uncertainty introduced by competing risk modeling, for which the original trial was not powered, of course. And finally, our framework quantifies time, not the lived experience of the patients. It does not account for quality of life, the disability after stroke, or on the other hand, the psychological burden of knowing that you live with an asymptomatic carotid stenosis and could experience a stroke in the future. So I would like to end with this statement. Early harm and late benefits in preventive treatments demand time-integrated treatment effects. I'd like to thank all contributors and thank you very much for your attention. I'm happy to answer any questions. Thank you.